Please see full important safety information at the end of this video. Metastasis to bone is a common and serious complication of many solid tumors, such as breast cancer, prostate cancer, and lung cancer. Bone lesions can also occur with other types of tumors that primarily grow in the bone marrow, such as multiple myeloma. The presence of tumor cells may cause weakening and loss of bone through disruption of the normal bone remodeling process. Normal bone is a dynamic tissue that undergoes constant remodeling. There is an equilibrium between the actions of osteoclasts, which resorb bone, and osteoblasts, which synthesize new bone. In the presence of cancer cells, the bone remodeling process is disrupted. Some tumor cells release signaling molecules that stimulate the growth, development, and activity of osteoclasts, resulting in accelerated bone destruction. The dissolved bone, in turn, releases growth factors that attract tumor cells and stimulate their growth and proliferation. This vicious cycle can result in accelerated bone turnover with extensive bone resorption and the development of osteolytic disease, and is commonly seen with metastatic breast cancer and with multiple myeloma. On the other hand, some metastatic tumor cells also release factors that cause aberrant activation of osteoblasts, resulting in abnormal bone formation. If the abnormal osteoblast activity is higher than the abnormal osteoclast-mediated bone resorption, the result will be net bone formation and development of osteoblastic disease. Osteoblastic disease is particularly common with metastatic prostate cancer. In many patients with bone metastases, there will be a mixture of osteolytic and osteoblastic bone disease, both within a particular bone lesion and between different lesions. Osteolytic and osteoblastic bone disease increase the risk of skeletal-related events, such as pathologic fractures, spinal nerve compression, and hypercalcemia. Zometa, zoledronic acid injection, with its double nitrogen molecular structure, is a strong inhibitor of osteoclast-mediated bone resorption. Patients with hypersensitivity to zoledronic acid should not take Zometa. Zometa is administered once every 3 to 4 weeks as an intravenous infusion over no less than 15 minutes. Patients may occasionally experience flu-like syndrome after a Zometa infusion. Because of its binding affinity to hydroxyapatite crystals, the majority of Zometa is presumed to accumulate in the bone within 24 hours after administration. Any drug remaining in the circulation is rapidly excreted by the kidneys. Because it is excreted by the kidneys, do not use in patients with severe renal impairment. Caution is advised when bisphosphonates, including Zometa, are administered with aminoglycosides, loop diuretics, and potentially nephrotoxic drugs. In patients with mild and moderate renal impairment, the dose of Zometa should be decreased. The targeting of Zometa to the bone is due to its high binding affinity to mineralized bone. During bone resorption, Zometa is released from the surface of the bone and actively ingested by osteoclasts, where it inhibits farnesyl pyrophosphate synthase, a key enzyme in the mevalonate signaling pathway. This suppresses osteoclast activity and induces osteoclast apoptosis. Zometa may thereby inhibit the accelerated bone turnover despite the tumor-mediated increase in the number and the activity of osteoclasts. The decreased bone resorption may result in decreased calcium release. Patients on Zometa should take calcium and vitamin D supplements. Zometa should be re-administered once every 3 to 4 weeks in order to replenish drug molecules that are removed from the surface of the bone during osteoclast-mediated resorption. Zometa may block the destruction of mineralized bone decrease the risk of skeletal-related events, and extend the time to a skeletal-related event in patients with metastatic bone disease due to solid tumors and in patients with multiple myeloma. Zometa should be used in prostate cancer with bone metastases that has progressed after treatment with at least one hormonal therapy. Zometa has been used in more than 3.5 million patients worldwide and is an effective treatment option for patients with multiple myeloma, patients with breast cancer, and metastatic bone disease, and is the only bisphosphonate to show clinical benefits in patients with bone metastases from other solid tumors, such as hormone-refractory prostate cancer and lung cancer.